introduction. It's wonderful to be here in person with you all again. Today I'll be sharing some of our recent work done with the help of my advisors, Catherine Kuchenbecker and Annie Hallilai, and our collaborators, Michelle and Riefberger. In this work, we're addressing two key issues that are currently keeping gait retraining from being commonly used in the clinic to slow the progression of knee osteoarthritis. The first is how to predict how a patient will respond to a gait retraining, and the second is where to find a sufficiently diverse biomechanics data set for an application as specific as gait retraining. The degradation of articular cartilage in knee osteoarthritis is mediated by joint loading. In the absence of in vivo measurements of joint load, the knee adduction moment, or CAM, is commonly used as a surrogate measure of knee loading. Now, not only is an increased CAM a strong predictor of osteoarthritis progression, it's also correlated with in vivo knee loading. So this graph shows the correlation between CAM and medial contact force for several representative subjects with instrumented knee replacements. So CAM reduction is therefore often the primary target for reducing load and sparing cartilage. Now, there are several ways to reduce the CAM. There are non-invasive methods like shoe modifications or knee braces. Surgery, such as a high tibial osteotomy, is an effective intervention, but it can be quite traumatic due to the recovery time needed. And complications, such as deep vein thrombosis, nerve damage, or rejection have been reported in 30 to 40% of cases. In contrast, gait retraining, or changing the way that a patient walks, has been shown to result in comparable reductions in CAM to high tibial osteotomy without the need for invasive surgery. Furthermore, a recent paired study has shown that proteoglycan depletion is spared when patients are taught to walk with a modified foot progression angle, thereby reducing their CAM and slowing down the rate of cartilage degradation. Now, while gait retraining is a highly effective intervention, not every patient responds the same way, and not everyone reduces their CAM by a clinically meaningful amount. In fact, some patients may even increase their CAM with the same intervention. Determining patient response to a gait retraining still requires lab instrumentation, and because not every patient will respond, this prevents gait retraining from being translated to the clinic. In response to this need, the goal of our study was to build a predictive model for patient response to gait retraining using minimal clinical data. We envisioned the use of simple features already collected in the clinic, such as height, weight, walking speed, and static knee alignment in the frontal plane, as well as foot progression angle, which could be easily estimated with wearable sensors. These model inputs would then be used to predict on a subject-specific basis how a patient would be expected to reduce their first peak of CAM after a toe-in gait retraining. However, for such a model to be generalizable to new patients, we need a large training data set with both baseline and modified gait. Now, although sharing data sets is becoming more common in biomechanics, traditional motion capture data is still resource intensive to collect. This is especially challenging for an application as specific as gait retraining, where the mean sample size for a study is approximately 13 subjects. The second goal that I address in this study is how can we create a synthetic gait retraining data set that is large enough to extrapolate to unseen subjects using the limited examples that we have access to. So in other words, how do we increase our available data by an order of magnitude to go from samples in the tens to samples in the hundreds? I'll begin by describing our process of creating a synthetic data set from limited examples. So first, we used a ground truth data set provided by Stanford University consisting of 12 subjects with knee osteoarthritis, walking at baseline and at toe-in. By learning the basic patterns of how gait changes with toe-in, we then applied those learned patterns to a large baseline gait data set provided by the Calgary Running Injury Clinic, consisting of 138 healthy subjects, to create a synthetic data set of toe-in gait. The synthetic data set was then used in our second aim to train a model to predict how a patient would respond to a gait retraining using the simple features that would be available in the clinic. However, we wanted to validate this work further and approximate a case in which this trained model would be employed in practice on unseen third-party out-of-domain data. So we collected a sample of 15 subjects walking at toe-in and baseline and compared the accuracy of their ground truth toe-in to the synthetic toe-in that we generated in aim 1, and finally tested our model on this independent data set to see how well it generalized. So I'll first provide a few more details on how we synthesized toe-in gait from baseline data. Toe-in gait reduces CAM by shifting the knee joint center medially and the center of pressure laterally. So we learned how the knee joint center and the center of pressure shift with a changing toe-in angle relative to the pelvis using the ground truth toe-in gait data. So we binned all of the steps from all the subjects based on their toe-in angle, and created average toe-in trajectories for the knee joint center and center of pressure for every toe-in angle. Now, given a toe-in angle, we could estimate what the knee joint center and center of pressure trajectories would look like for a given subject, and used a leave-one-out cross-validation on subjects to evaluate our synthetic gait. So here we see a medial-lateral knee joint center for a single representative subject plotted over percent stance, so heel strike to toe off, relative to the pelvis center. Baseline knee joint center is shown in solid gray, and you can see that both the synthetic trajectory in red and the ground truth toe-in in blue capture that medial shift in the early half of stance. So we use these synthetic knee joint center and center of pressure trajectories to compute the CAM. First on the ground truth data set with the leave-one-out cross-validation. Here you see CAM plotted over percent stance, scaled to percent body weight times height, with baseline in solid black, ground truth in blue, and synthetic in red. We found that the RMSE of the entire CAM trajectory was approximately 0.2% body weight times height. And we then tested our synthetic toe-in CAM on the independent data set, again finding that the synthetic CAM correctly captures that expected reduction in the first peak of CAM. We found that the RMSE here was approximately 0.3% body weight times height, which was not significantly different from that of the Stanford data set. So after gaining confidence in the ability of our synthetic data generation approach to realistically generate toe-in gaits and enable modeling of the outcome of interest, which is that reduction in the first peak of CAM, we moved on to the main goal of the study. So in our second aim, we determined if minimal clinical data would be sufficient to accurately predict response to gait retraining. So again, we're using those 6 simple features, and we trained a linear regression model on the synthetic data set to predict reduction in the first peak of CAM. We trained the model on 110 synthetic subjects, which are shown here in gray, and evaluated this model on a holdout data set of 28 synthetic subjects shown in red. We found that the mean absolute error of the predicted CAM reduction was about 0.8% body weight times height, 0.08% body weight times height. And we next evaluated the model on ground truth toe-in data, again finding that the model performed well. Here, our mean absolute error was 0.13, which was not significantly different from the error of the synthetic data set. Furthermore, this error was actually smaller than the average standard deviation of the first peak of CAM during these subjects' baseline gait, or in other words, the prediction was accurate to within the deviation you would normally see when these subjects were walking normally. So this is important as it tells us that the model that was trained on synthetic data will not show a significant reduction in accuracy when tested on ground truth data. So of the 6 features that we used in the model, the toe-in angle, static alignment, and weight were the most significant predictors of CAM reduction. Toe-in angle was the strongest predictor, where an increased toe-in angle was predictive of a greater reduction in the first peak of CAM. And this is consistent with previous findings in an osteoarthritic population, which gives us confidence in the validity of this feature. The next most salient feature was the static alignment of the knee joint in the frontal plane. So here we found that an increased valgus angle during alignment was related to a smaller CAM reduction. And again, this result supports a previous finding that CAM reduction is greater in participants with a more varus or non-heel alignment. Patients with a varus alignment tend to have a greater CAM at baseline, which may enable them to have a greater CAM reduction overall. Finally, although the CAM was normalized to height and body weight, weight was predictive of a smaller CAM reduction. Now, because neo-weight patients with a higher weight have a larger weight normalized CAM relative to their lean age-matched osteoarthritic controls, it's not yet clear why individuals at a higher weight might have a harder time achieving significant reductions in CAM despite their larger CAM at baseline. I'd also like to note that there are a few limitations that should be considered before we can be ready to deploy this model in clinics. First, in order for this model to be accepted by clinicians, it must be tested on a patient population. Although we validated the model on an independent data set, it's not yet been tested on a clinical population, and we haven't linked the predictions of the model to any clinically relevant measures such as pain reduction or improvement in function. However, the toe-in gait used in the synthetic data generation does come from neo-weight patients and show consistent accuracy and cross-validation, which gives us tentative confidence in the model's ability to generalize. Furthermore, in this model, we're only providing predictions of toe-in gait, although toe-out has also been shown to result in significant reductions in CAM. The model could be improved in the future with the inclusion of additional data sets that feature toe-out gait. So by openly sharing both our model, code, and data, we hope to make it easy for the future integration of a toe-out data set that would enhance prediction. Finally, I should note that the features presented here don't span the space of all possible relevant features, right? Knee or hip angles will also be very relevant to predicting patient response. So in the future, features that are extracted from video or wearables may be integrated into a predictive model without sacrificing the ease of use that we have now. However, the benefit of the model that I'm presenting here is that we can enable accurate prediction of an expected gait change without the need to collect baseline kinetic or kinematic data. The model generalizes without loss of accuracy to out-of-domain data and can predict cam reduction using easily interpretable features. So to summarize, I showed here a way to use synthetic data as a way to overcome limitations in data quantity for a specialized task like gait retraining. I found that a simple set of features can be used to predict retraining response without the need for laboratory instrumentation. And finally, we encourage the use of independent data sets to test predictive models as a way to evaluate their effectiveness in translation. Ultimately, both the issue of gait retraining prescription as well as a lack of large training data are hampered by the same fundamental challenge, which is that traditional gait labs are not widely accessible. So we imagine a future world where instead clinicians can use low-profile sensors, patient-specific predictive models to customize treatment without relying on gait lab instrumentation. So I hope that our work here can contribute to a vision of bringing gait lab capability to the clinic. If you're interested, here's a QR code to the paper. It has plenty more details, but I'm happy to take your questions now, or feel free to find me at any other point during the conference with any thoughts you might have. Thanks for your attention.
We have time for one quick question. Yes.
Hi, my name is Leo Song from University of Illinois Urbana-Champaign. Great talk. My question deals with how do you determine the threshold for the maximum absolute error? So what is an acceptable value and what's not? Because I was always curious with different validation studies, they have specific values, and usually they refer to literature, but it's also not clear why they chose a specific number as their sufficiently accurate number.
Absolutely, thank you for that question. We did not set a threshold for what would be an acceptable MAE, but you're right in that there are different thresholds that one could use to determine if the accuracy of the system is clinically relevant. So oftentimes in previous literature, people aim for a reduction in CAM of about 0.5% body weight times height. An error that would be maybe an order of magnitude less than that would result in a pretty consistent result. Here, the cool thing that we found with our results is that they were accurate to within the standard deviation that you'd see in people's baseline gait. So if you were to walk across a force sensing platform in a gait lab right now, and your CAM would vary by 0.02% body weight times height, whatever intervention I give you, whatever accuracy I would need to find would need to be within that standard deviation.
Thank you.
Thank you.